Hi friends, welcome to discussion of Pathology Paper 1 of RGUHS August 2025. Me Dr. Manjunath, known as FMT Guru, the faculty at Subbaiah Medical College Shivamogga and mentor at RGUHS Mentorship Offline Center Shivamogga for first MBBS, second, third and final MBBS students. Yes, how was the paper? Easy, moderate, difficult? So as per feedback from our offline center students, the paper was easy to moderate, not that difficult, moderate to easy. So we are going to discuss brief answers in 15 to 20 minutes maximum. So let's start with the main questions and what to write, short essays, what to write, short answers, what to write, and the MCQs and answers. So the first main question, 30-year-old male presented with the loss of weight, loss of appetite, evening rise of temperature of 3 months duration. So it's a chronic inflammation. Cervical swelling biopsy showed amorphous cellular material surrounded by epithelioid granuloma. So it's basically caseating granuloma. So the answer is, what is the answer? What is the likely clinical diagnosis? It's basically tuberculosis. Okay, so the answer is tuberculosis. Define necrosis, describe the types of necrosis. Add a note on differences between apoptosis and necrosis. So it's a offline mentorship repeat. We discussed many times in our offline classes. So the answer is tuberculosis. So types of necrosis, you need to write about coagulative necrosis, the most common type of necrosis. It's one of the most common cause of ischemia, seen in all solid organs except CNS. So what are the examples? The heart and kidney. The second one, liquefactive necrosis, known as colic-fatty necrosis. It is because of release of hydrolytic enzymes. So it is commonly seen in CNS, that is because of the damage to the glial cells. The fat necrosis associated with organ with high concentration of lipases. Example, breast tissue and omental tissue. Caseous necrosis. In caseous necrosis, you will see cheesy like necrosis, combination of coagulative and liquefactive necrosis, seen in case of tuberculosis, fungal infection and syphilis. Fibrinode, basically seen in blood vessels. The example, malignant hypertension, so characterized by Ashcap body and others. Right. So you need to write about the types of necrosis: coagulative, liquefactive, fat, caseous and fibrinal necrosis. Then you need to explain a few points about the coagulative necrosis. So what is the definition, causes, appearance, macroscopically and cellular details and the mechanism. Same way, liquefactive necrosis, caseous necrosis, fibrinal necrosis and all. Gangrenous necrosis, again very commonly asked. And if you mention few points like apoptosis, necroptosis, paroptosis, pharoptosis and all, so it will fetch you more marks in the exam. Okay. Yes. Then differences between necrosis and apoptosis. So this you need to write basically definition, process, cell death, type, cell size, plasma membrane, inflammation and the marker. Okay. So the differences, at least some 5 to 6 differences you need to mention to get passing marks. So this is about the main question. The question number 1, very easy from the repeat, that is basically necrosis and apoptosis. Apoptosis is that is a programmed cell death, genetically programmed cell death because of the caspases. The second question, a 25-year-old male with the splenomegaly, episodes of epistaxis, the bleeding is there because of the thrombocytopenia, revealed high WBC count more than 20%. It's more than 20% with a high NC ratio, lacy chromatin with 1, 2, 3 nucleoli. Cytoplasm showed presence of R rods in most of these cells. What is diagnosis? discuss WHO FAB classification. You need to discuss WHO and FAB classification, and also need to discuss about cytogenetic abnormality associated with this condition. So this is basically AML. So AML, that is acute myelocytic leukemia or acute myeloid leukemia. So lacy-chromatin is a characteristic feature of monoblast found in acute myeloid leukemia AML M5. So this is basically M5. So basically in M5A, that is acute monoblastic leukemia, and M5B, that is acute monocytic leukemia. So these cells along with the promyelocytes, so promonocytes are the primary blastine in this type of AML. So, and again, what is the FAB classification? As you know, M0, M1, M2, M3. You need to write about M3, M2, M1, M0. What is the common name? What is the morphology? What is the cytochemistry? What is the protein marker, like this? Then M4, the same way up to M7. Then WHO classification. WHO classification, you can see here AML with genetic aberrations, AML with MDS-like features, AML therapy related, AML not otherwise specified. So this is WHO classification. So you need to mention about FAB classification as well as the WHO classification and FAB classification both. So the basic difference between the both is the cutoff of percentage of blast in bone marrow for diagnosing AML in FAB, that is 30%, but in case of WHO it is 20%. So in the question it is given more than 20%. WHO classification based on cytogenetic abnormalities and indicates a prognosis which is not present in the FAB classification. So these two are basic differences between WHO and FAB classification. This is taken from Robbins. Now, what are the cytogenetic abnormalities and prognosis? So there are common cytogenetic abnormalities. So de novo AML with the young adults, that is 821, inversion 16, and 15 and 17. So 15 and 17 commonly associated with acute promyelocytic leukemia, which has best prognosis, the curable in 90% of targeted therapy. Are therapy related AML after DNA damaging agents, like example monosomy 5 and monosomy 7, TP53 mutation, which has a poor prognosis. After topoisomerase 2 inhibitor therapy, so which has a worse prognosis, that is the KMT2A gene rearrangement. So I think if you write these points, FAB classification, WHO classification, and the diagnosis and cytogenetic abnormalities, you will get at least 7 out of 10. Then comes is the very important most common anemia in India, that is the iron deficiency anemia. Basically the question asked about laboratory investigation. So in laboratory investigation, you need to write this table. We discussed many times in offline classes. So screening test, diagnostic test, and special test. So what are screening tests? Hemoglobin, RDW, MCV, MCH, MCHC, RBC count, reticulocyte count, WBC, platelets, and all. Diagnostic basically serum ferritin, serum iron, TIBC, that is the total iron binding capacity, transferrin saturation, and all. Special tests like example FEP, ZPP, bone marrow iron store, and bone marrow morphology. So if you write this table, you will get at least 3 out of 5. So again it is taken from the Robbins. Mention the anticoagulants in blood bank. So it carries 2 marks. Write a note on blood bank used in blood banking basically. So mention the anticoagulants. So maybe 2.5 and 2.5. So for whole blood we use ACD, that is acid citrate dextrose, or CPD, that is citrate phosphate dextrose solution, citrate phosphate dextrose adenine, CPDF1, heparin, and EDTA. What is EDTA? Ethylene diamine tetraesteric acid. Red blood cells we use CPD SAG, S for saline, A for adenine and glucose, CPD CAGM, saline, adenine, glucose, and mannitol, CPD adsol, that is basically adenine, saline, glucose, and mannitol. So red cells in the frozen state we use high glycerol solution and low glycerol solution. If you write this, you will get 2 marks out of 5. Then the question is, what are the different types of blood bags? So to simplify, there are 4 types: single bag used for whole blood collection, double bag used to separate packed cell and the plasma, triple bag basically packed cells, plasma, and platelets, quadruple bag used to separate packed cell, plasma, platelets, and cryoprecipitate. If you write this, you will get 2 marks out of 5. and you need to explain about all these bags. So then this is what the double bag, so around 350 ml that is, and this is about the triple bag, so that is 450 ml bag. So then what are the cellular events in acute inflammation? So last year exam vascular events, this year exam cellular events. Again it's a repeat from RGUHS mentorship program, so offline program. So there are findings like example increased neutrophilic influx in the vessels. So there will be margination, there will be rolling. So rolling because of the selectins, types of selectin you need to write. Adhesion because of the integrins, types of integrins. Then transmigration known as the apidices. Chemotoxis, what are the chemokines? CXC chemokines, CX3 chemokines, CC chemokines, and C chemokines. And there will be opsonization and the phagocytosis. So all these are basically cellular events. I think if you mention these, you will definitely get 3 out of 5. Then if you some student also mentioned about the chemical mediators of inflammation, like cellular mediators and plasma mediator. It is asked once in the previous exam. So cellular mediators example newly synthesized and preformed mediators. Plasma maybe factor 12 activation, a complement activation. So if you write these points additional with the events, so you will get 4 out of 5. Differences between benign and malignant neoplasm. One more very simple question: benign and malignant neoplasm. So the answer is there are few points like spread. The metastasis is a feature of malignant tumor. So rate of growth, boundaries, relationship to the surrounding tissues, differentiation, cell orientation, blood supply, growth limits, effects and the treatment, and some examples you can write. Like adenoma, they're basically benign. Like example, pleomorphic adenoma, which is benign tumor. So carcinoma like hepatocellular carcinoma, which is the malignant tumor characterized by the metastasis. So you can also explain about the metastasis and the mechanism of metastasis if you have time. Describe the mechanism of cell-mediated immunity. You know, immunity, there will be one question, either acquired immunity or cell-mediated immunity. So innate immunity and all. So the question asked is cell-mediated immunity. So it is caused by the cell. So it needs MHC basically. Needs major histocompatibility complex before antigen presentation to T cells. It involves helper T cell, that is known as CD4 cell, and cytotoxic cells, that are known as CD8 cells. There are 3 steps: the step 1, step 2, step 3. Step 1, T cell activation by displaying antigen fragments to the MHC molecules. Step 2, T cell binding and activation. Step 3, activated T cell differentiation into effector and memory T cells. If you write these points, you will get at least 2.5 mark out of 5. Then etiopathogenesis of septic shock. I think previous exam it was asked as a main question. This exam it is a 5 marks question. Etiopathogenesis. So this table you need to write. We discussed many times in offline classes. So that is factor 12 here, complement, activation endothelial cell. So all this you need to write. If you write this table, you will get at least 3 out of 5. And also need to mention about the interleukins, interleukin 6, interleukin 8, nitric oxide, and ROS, that is reactive oxygen species. Also about the immunosuppression, systemic effects, vasodilation, intrapermeability, decreased perfusion, multi-organ failure because of the microvascular thrombosis and all. There will be PI1 increases, increased TF and decreased thrombomodulin and protein C. So these points should be there in your answer. So you will get at least 3 out of 5. Then multiple myeloma, one of the favorite question. So multiple myeloma, it's a tumor, it's a carcinoma of old age, commonly involves the vertebra, as you know. So we discussed many times in our offline classes. So basically it occurs in old age. So we remember as old age cramp. So old age cramp, C for calcium elevated, R for renal failure, A for anemia, and bone lytic lesions. So osteolytic lesions, punctured out lesions are very common. So and it's a plasma cell tumor, monoclonal plasma cell tumor. You will see M protein in the serum and the urine, and melphalan that is used for treatment. So diagnosis we use electrophoresis, benzoin protein and all. If you write all these points, you will get at least 2.5 out of 5. Then comes the last 5 marks question, FNAC. So FNAC, what is FNAC? Question asked. Describe different methods of FNAC and what is the role of FNAC, advantages, disadvantages. Again, repeat question, many times is asked. So yes, so FNAC done. Then 3 marks question, metastatic calcification. So metastatic calcification and pathology classification, again it's a repeat topic. So in metastatic you need to write about in metastatic there will be serum level increases, there will be hypercalcemia, there is a deposition of calcium in the living tissues. Like example, PTH is increased, vitamin D increased, milk alkali syndrome, and the cancers. In the same way, just remember dystrophic calcification, D for dystrophic calcification, D for dead tissues. So it is associated with all these conditions: rheumatic heart disease, atherosclerosis, tuberculosis, tumors, meningioma, and all. And some of our bodies are seen in dystrophic calcification. So if you write these points, so you will get 3 out of 3. It's like a mathematics. Then fate of thrombus, repeat question. So either it can be occlusion, propagation, embolization, organization, recanalization, and dissolution. If you write this, you'll get 3 out of 3. Then name the 3 tumor suppressor gene, again from the mentorship program. So we have retinoblastoma gene, the chromosome is 13, so it occurs in the nucleus, the function is cell cycle. We have P53 known as guardian of genome, chromosome 17, the location is nucleus, DNA repair, and apoptosis. Then you can write BCL2 chromosome 18, so mitochondria, it helps in apoptosis. So APC also you can write, BRCA2 also you can write. So all these are basically tumor suppressor gene. Any 3 genes along with the function, you will get 3 out of 3. Then comes is a packed cell volume. Again repeat question. So packed cell volume, normally it is 45. So ratio is 45 to 55. This is the hematocrit basically. It rises in case of polycythemia, decreases in case of anemia. If you mention definition and increases and decreases in certain condition, you will get 3 out of 3. Then CSF finding in TB meningitis, this can be asked in your paper 2 as well. This can be asked in microbiology as well. So TB meningitis, what happens basically? So in TB meningitis, so there will be a fibrin web formation, point number 1. Protein level, so it can be slightly increased. Glucose level, so glucose level that can be decreased. So then glucose, CSF and serum ratio less than 0.4, and white cell count is around 100 to 500. So monocytes are commonly seen. So all these are the features of fungal or tubercular meningitis. So if you write any 3 points, you will get 3 out of 3. So then comes is your name 6 factors in wound healing. So you can write few points like example age. So you can write nutrition status, the vitamin C and all. Habits, so smoking, alcohol, drugs, hormones, steroids, chronic disease, inflammation, Crohn's disease and all. Advanced age and hereditary, infection, neurological defects, compromised vascular perfusion, local pressure, physical, chemical damage. If you write any 6, so you'll get 3 out of 3. Then comes is name 3 causes of massive proteinuria. So massive proteinuria can be seen in various conditions. It can be seen in case of nephrotic syndrome. It can be seen in chronic kidney disease, diabetic nephropathy, that is basically kidney disease, focal segmental glomerulosclerosis, FSGS, glomerulonephritis, so that is nothing but inflammation. So in children basically nephrotic syndrome, in adults basically it is diabetic nephropathy. You can write any 3, you will get 3 out of 3. Then comes is your tumor markers. So tumor markers again repeat question. So tumor markers can be anything, like example alpha fetoprotein, hepatocellular carcinoma, carcinoma embryonic antigen, like example colon, pancreas, lung and stomach, heart carcinoma. So right, okay. Then you can write about some other finding like CA19-9 colorectal cancer and pancreatic cancer, CA15-3 breast cancer. So then you can write any 3, you will get 3 out of 3. Okay. EGFR repeat question, KRAS, BRAF, all these are repeat question in the previous exam. Calcitonin basically in medullary carcinoma of thyroid, pheochromocytoma, that is basically catecholamines. So all these are basically tumor markers. Any 3 with a carcinoma will get 3 out of 3. Reed-Sternberg cell, that is basically Hodgkin's lymphoma, one of the simplest question. So what is Reed-Sternberg cell? You need to define. So where is it seen and what is the appearance? So Reed-Sternberg cells are large abnormal lymphocytes, basically large abnormal lymphocytes that may contain more than one prominent nucleus with a perinuclear halo. So these cells are seen in case of Hodgkin's lymphoma. So you can remember the mnemonic, read books like a owl who does not sleep at a time. So that is owl-eye appearance. Become HOD of your favorite brand, that is basically Hodgkin's lymphoma. This is what we discussed many times in our classes. So this is basically a Reed-Sternberg cell. You can write about types of RS cells in different types of Hodgkin's lymphoma. So that is actually you will get 3 out of 3. Then draw label diagram of case-shaping granuloma, that is basically tubercular granuloma, case-shaping granuloma. You need to write this diagram. So in diagram you need to show Langhans giant cells, clusters of epithelioid cells surrounded by lymphocytes. You will get 1 mark. Epithelioid cells with the pale elongated nuclei, you will get 1.5 marks. And at the end you need to write amorphous, eosinophilic, granular, dendritic material with a complete loss of cellular details. So this is what known as caseous necrosis. It's a subtype of coagulative necrosis. There will be some findings of liquefactive necrosis as well. The classical is tuberculosis. So this completes your all short answers. Then comes is your MCQs. Opsonization seen in, very simple. Opsonization is a part of phagocytosis. Okay. Diapedesis is a transmigration. Chemotoxis is a unidirectional movement of the neutrophils. So activation of NADPH basically that helps in opsonization, and also in case of phagocytosis basically it is a B correct answer. Burkitt's lymphoma. So Burkitt's lymphoma, the answer would be that is CYMYC. That would be the correct answer. Which of these is a X-linked dominant disorder? X-linked dominant, not recessive. Hemophilia is recessive, you know that. So the basically it is vitamin D resistant rickets. So C is the correct answer. So what are the X-linked dominant condition? The mnemonic is Ravi. R for Rett syndrome, A for Alport syndrome, vitamin D resistant rickets, incontinentia pigmenti. And X-linked recessive disorder, there is a well-known mnemonic that is Lady Hamirpur college girl, don't care about foolish words. Alpha Leishman syndrome, hemophilia A and B, Hunter disease, color blindness, GCHPD deficiency, Duchenne muscular dystrophy, chronic granulomatous disease, agammaglobulinemia, Fabry disease, Fragile X syndrome, and Viscoach-Aldrich syndrome. So this can be asked in your paper 2 as well. So try to memorize X-linked recessive and X-linked dominant condition, autosomal recessive condition, and autosomal dominant condition. So one example for autosomal dominant condition can be asked in paper 2, that is neurofibromatosis type 1, chromosome 17. Then comes is the MCQ. A 25-year-old female with amenorrhea was evaluated, found to have hemoglobin certain level, reduced serum iron, probably it's iron deficiency anemia. Peripheral smear showed anisocytosis. The question asked is anisocytosis. The question is very simple. Anisocytosis means, so aniso, I remember like this, S for size, and poikilocytosis basically shape. So this is a different size of RBC that is seen in iron deficiency anemia. B is the answer. LE cell. What is LE cell? So LE cell is a neutrophil containing damaged cells. It can be seen in SLE. So 30-year-old male, pure vegetarian. Whenever word pure vegetarian, restlessness, tingling, numbness sensation, there will be vitamin B12 deficiency, no doubt in that. Philadelphia chromosome, remember this is a very common MCQ, that is chronic myeloid leukemia, that is 922 translocation. Next comes is your, what is LE cell? LE cell is a lupus erythematosus cell, is a type of white blood cell. It's a type of white blood cell, basically neutrophil macrophage that has engulfed and digested denatured nuclear material of another cell. So it is commonly seen in SLE and other autoimmune condition. So then comes is, which of the following is a bleeding disorder? Very simple question. So bleeding disorder, sickle cell anemia is a different sickle shaped RBC. Thalassemia is because of the deficiency of chains of beta globins, beta thalassemia, alpha thalassemia. Hereditary spherocytosis is definitely spherical shape. So the answer is idiopathic thrombocytopenic purpura. Sago spleen and Laudacious spleen, so commonly seen in amyloidosis of the spleen. We discussed many times. Last question, a bit controversial question. So which of the following antibodies may be identified on laboratory testing in a patient with systemic lupus erythematosus, except is there? So if except is not there, then it is anti-double stranded DNA is the correct answer. If except is given, then I'll go with the Jo1 antibody, because anti-double stranded DNA is seen, SS is also seen, SSB is also seen. So answer is Jo1 is the correct answer. If except is not given, then that is anti-double stranded DNA is the more accurate answer than the B and C. So this completes your discussion of the paper. And as per my calculation, so our mentorship program, the offline center, it's around 90% exact lines from notes. Yes, you don't worry about now the mistakes. You know, concentrate on paper 2 and revise all the important questions and attempt all the questions tomorrow. Thank you.